So now we are going to take some questions. I don't know if anybody has questions related to Dr. Parvin and Professor Clark's lectures. Some people have typed some in the chat box already. I don't know if there are others who haven't typed their questions yet. And please, we noticed that some people are asking a very very professional questions. This Harmattan school is meant to create more awareness on the role of physics and engineering in medicine. So it's not actually meant for very advanced people. So if people are asking some very clinical questions, please, I would like us to restrict our questions to the content of the lectures being delivered. And during the week, you will notice that there are more specialized courses, so we can take more specialized questions then. But please, if you're already an advanced clinician or something, this is not really the right avenue. There are lots of undergraduate students who have no idea of what medical physics is all about and want to, as much as possible, pay attention to them first. So please, if you have questions, kindly ask. So I'll quickly start from Dr. Parvin. That was a very good lecture. Thank you very much, ma. So some questions for you. So someone asked, after the successful use of radiotherapy to destroy tumors, what happens to the destroyed tumors in the body?
I saw that question, and I'm afraid I have to confess I don't know the answer. I guess that you've got dead cells, and therefore they will be removed and reabsorbed. But
Yeah.
I'm not a medic, and I can't answer that question. I don't know whether you can.
Sorry, please mute yourselves. Please do not unmute yourself except you are asked to, please, for the sake of order. Hello? Dr. Parvin?
Yes, I'm still here.
Oh, okay. So yes, basically what radiotherapy does to the tumor is to fry the tumor, to burn it. So I think that's just what happens, and whatever is left is expelled from the body. I think so.
Yes, I think
so.
so.
Yeah. So there's another question for you. Someone said, okay, what is the career prospect in medical physics for someone who studied radiation protection at master's degree level? Can such a person work as a medical physicist?
Well, I have to confess I don't know the system in Nigeria, and you can, I'm sure, answer that one. In the UK, we do have a system, a government system for students who've got a degree in physics or engineering to go and work in a hospital, and also to do an MSc in medical physics, which they have accredited. But we have a lot of other people who do an MSc in medical physics and get a job in a hospital, and then go through a process of approval by the Association of Clinical Scientists to become a registered clinical scientist. I don't know what the solution is, what the situation is in Nigeria, but I would have thought that someone who has a degree in physics and a qualification in radiation protection would be an ideal person to go and work in a hospital. As I said, there are a lot of people in hospitals working in radiation protection.
Okay, so the system in Nigeria is quite different. In the UK, you have to, after your degree, then you get into the scientific training program, and then you get trained as a medical physicist, after which you take some exams before you can start, before you are qualified or certified to practice in the hospital. But in Nigeria, you have to have your master's degree first in medical physics. So radiation protection is a subset of medical physics, it's just one aspect. So most medical physicists work as radiation protection scientists. Radiation protection, the course contents are totally different. So in Nigeria, to practice as a medical physicist, you have to have a master's degree in medical physics. So having a master's degree in radiation protection is not enough. You are not taught well enough, you know, all the knowledge you need to practice as a medical physicist. So
yeah, well, I mean, in IPEM, we do have an accreditation system for MSCs. The only one outside the UK at the moment is in Malaysia, but we have an accreditation scheme, which I'm very much involved with. And what we do is we accredit MSCs, but we do look at them to see that they include enough of every part of medical physics, maybe with a specialism in one area like radiation protection, but they need to include all the other stuff as well. So, because I feel people need to be aware of all the other different areas of medical physics.
Yes.
I mean, these days, for example, it's no good knowing about imaging if you don't know how it's involved in radiotherapy, which is becoming more and more important. So yeah, but I can't answer for the system in Nigeria.
Yeah.
Good luck
Okay.
with it anyway.
Thank you. Okay. So there's another question. Do physicists play a particular role in equipment design? So for example, in design of a linear accelerator that you mentioned, do
Sorry,
physicists have a role to
in
do
design of what?
physics of medical equipment? So example, a
Right.
linear accelerator.
Yeah. To do that kind of thing, you would probably be doing either work in research, or you might be working for a company who actually make and develop these kind of machines. I mean, the linear accelerators are made by companies. Um, Dan may be able to answer this one better than me, but they're made by companies like Electra and so on, and they have quite large research and manufacturing facilities. And quite a lot of people who've got degrees in medical physics, some of my own students have done this, actually work for these big companies. So you can get into it that way as well.
It's a really good question. And one of the things that's fantastically exciting about the field is that you get to work with lots of different people. So I just mentioned in my presentation three examples of innovation of new technology. And in the first one of those, we were working with a team of physicists, and the physicists were optical engineers, so they understood about light interaction, and they built that machine. In the second example, we were working with a manufacturer who made fabrics. Bizarrely, you might not think that a manufacturer that makes fabric would be somebody that would then go on to make a medical device, but some of the clever fabrics they make are able to measure pressure and temperature in the skin. They design their fabrics primarily for elite sports people. So elite sports people wear clothes which can measure their heart rate and their temperature and their pulse. And we got together with them because they can also measure things in healthcare. So it was exciting that the physicists that were making these fabrics for a manufacturer ended up making a medical device with us. And then in our third example that I showed you, we were working with mechanical engineers, both from Nottingham University, but also from a manufacturer of cars, so from Jaguar Land Rover. So whether you're a physicist or an engineer, whether you're a mechanical engineer or an optical engineer or electronic engineer, so one of the excitements of working in healthcare is that you'll find yourself working with doctors, with nurses, with patients, and then possibly with manufacturers from all sorts of different areas. Certainly physicists get involved in the design of linear accelerators, which was the specific question, but physicists get involved in the design of all manner of medical devices that are out there today.
Yeah, it's all about collaboration, isn't it? Between
it's
different.
It's all about collaboration, absolutely, yes.
And respecting other people's knowledge. Yeah.
Thank you very much.
Okay, there's a question. The question just popped up. I'd love to answer, if I may.
All right, please do.
Sunday has just asked about if X-rays can cause damage, why use it? Well, the answer is what I mentioned at the end, which is justification. Before the days of X-rays, you couldn't find out, even if you've got a broken bone, really, without cutting the patient open and having a look. And the X-rays give you a chance to have a look. So the X-rays are very definitely beneficial, but you're absolutely right. You have to look at the potential damage to a patient. Now, we have a way of measuring the amount of radiation that a patient receives, and the effective dose is measured in a unit called a sievert or a millisievert. And we can actually work that out and know that if you have a CT scan, you have a certain dose. Now, you've got to look at this in a logical way. You've got to say, okay, we live in a world where we get background radiation every day, all the time. We are getting background radiation, and we know how much background radiation we get. It's in the UK. I don't know what it's like in Nigeria, but maybe you can tell me. We get something like 2.5 millisieverts a year, a bit more than that. Now, if you go and have an X-ray, well, if you go to the dentist and have an X-ray, it's absolutely negligible. If you go and have a CT scan, you might get a few years worth of background radiation. But on the other hand, if by having that CT scan, you actually find out what's wrong with the patient and you can treat the patient and give them a lot more years of decent life, then that's worth it, isn't it? You've got to look at whether it's justified in doing anything. If you've got somebody who's been in a road accident, you put them in a CT scan, you can see straight away what's wrong, and you may very well be able to save their life. So it's very much worth it. Again, with radiotherapy, you're giving larger doses of radiation. But again, you are extending their life. So it has to be very, very carefully worked out and very carefully justified. Yes, it's a very good question, and it's something which physicists are looking at all the time. I mean, the hospital I work most closely with have a radiation protection committee, and the radiation protection committee meets regularly and discusses all sorts of aspects of radiation protection in the hospital. Things that went wrong or might have gone wrong if somebody hadn't stopped it, and things like that. So yes, it's a very good question, and it's something we are constantly asking. I hope that answers the question.
Yes, yes. The key word is justification. I mean, you have to choose between saving the person's life and worrying about a few cells that are damaged. So that's it at the end of the day.
Yes, and the problem, as I say, you've got to remember that we are all getting background radiation all the time. None of us say we're not ever getting any radiation. So, in fact, if you go in an aeroplane, if I get in an aeroplane and fly to Nigeria, I will be getting an increased dose of radiation. Now, the one we always use is a flight from the UK to Spain, which is what, 2 or 3 hour flight, is about the same as a chest X-ray. So,
yeah. So even without going into the hospital to take an X-ray, you are still at the risk of getting exposed to background radiation. Yeah. Okay. So another question. Okay. So Professor Clark, this is for you. So can an engineer work as a medical physicist, and can a physicist work as a clinical engineer? So,
possibly, it depends. I mean, I started out life as a physicist, so my first degree was in physics. My PhD is in optical spectroscopy. But when I started working in a hospital, I started to get involved in design of equipment to support treatment, and so I developed much more into the engineering aspects than I did in the physics aspects. So I'm aware of a lot of engineers who were originally physicists, and indeed a few physicists like themselves who were originally engineers. So you can go both ways. I think it's important, though, to realise that if you're working in some aspects of physics, there's some aspects of physics that you just wouldn't get if you hadn't had a physics degree. You wouldn't be able to pick up very easily. And there are some aspects of engineering that you would struggle to pick up if you haven't got an engineering degree. But I think, it's something we said earlier. One of the joys of working in this profession is that it's multidisciplinary. Most of the work that I do in the hospital, I'll bring the engineering expertise, but I'll work with a physicist who will bring the physics expertise, and vice versa. So that's a waffly answer, wasn't it? In truth, you can go from one to the other, but if you're a specialist in one area, it's possibly quite difficult to get into that. I couldn't possibly be a radiation protection advisor, for example. I wouldn't have the background in radiation physics to do that. But yes, so there is some flexibility. Let's just leave it at
that. Okay, thank you. So I mean, it's the same in Nigeria. You have to be a medical physicist. I think it's global too. You need to have a first degree in physics or engineering. So that's because most times you find out that physics and engineering students take similar courses. But there's a question I would just want to answer. So someone is saying, can having a master's degree in medical physics, irrespective of your first degree, enable you to practice? The answer is no, not in Nigeria. To be a medical physicist, you have to have a first degree in physics. Medical physics is the application of physics in medicine. So what are you going to be applying if you didn't study physics or something like engineering? I mean, you can't study a course like food and nutrition and expect to be a medical physicist. It doesn't make sense. You're actually applying physics concepts, principles in medical physics. So you make sure your first degree is right. So, okay, so there's another question. So how can research, undergraduate research in specifically speaking now, from the university be integrated into clinical practice? So I don't know if you want to say something. I have an answer anyway. So how can undergraduate research from the university be integrated into clinical practice? I'm sure the answers are going to be different from the Nigerian and the UK perspective. they are not the same. So you want to say something?
Yeah, undergraduate research would be unusual to find in the UK. It would be unusual to find an undergraduate research project that was then brought forward into clinical practice. At master's level, it's different. We use a lot of master's students. There are lots of problems and challenges that face us in healthcare, and we're running projects all the time to try and improve healthcare. Clinicians will come to us in medical physics and clinical engineering and say, would it be possible to measure such and such a pressure in the bladder? Or can I measure the temperature at this part of the brain? Or is it possible you can build me a wheelchair that I can adapt to do so and so? So people will come to us with problems all the time. And medical physics and clinical engineering is a relatively small team of people in the hospital, and we can't do all those research projects on our own. So we often go across the road and get a local university involved, and we'll have a project team, and sometimes it's the master's students who spend 2 or 3 or 4 months on the project who really make it happen, supervised by a senior member of staff, supervised perhaps by somebody working in the hospital, but they do the research, and that often develops into something which we then take forward into something which gets implemented into healthcare. Undergraduate physics and engineers generally don't have enough time in their projects to really get to grips with something important in a healthcare environment. It does happen, but it's quite rare.
I'd agree with that, Dan, but I would say slightly in the defense of undergraduate projects. I have worked with undergraduates who did projects in the hospital for their final year project. Usually the best thing that comes out of that is that the physicist decides that, yes, I'm going to go for a career in medical physics.
Yeah.
I've had quite a few of those. But occasionally they are sort of starting off a project, which, as you mentioned, would then possibly be picked up by an MSc student later on. But I agree with you completely, they wouldn't have very much time to produce very much, but they might be, starting to develop a phantom for something or something like that. But as I say, the main effect is, I'm going to go into this as a career. And I've had quite a few students who've done that. Yeah.
So I'm a typical example. My undergraduate project was related to medical physics. And that was because I already knew about medical physics from my first year. And I made up my mind that I was going to do a project in medical physics. So I got in touch with the clinical staff who gave me a project. So, most times people just come up with project ideas from the internet, and you can't just do any kind of project and expect that it's going to be automatically implemented in clinical practice. You have to actually be solving the problem. So if you want to know the problems that exist in the clinical practice, you need to get in touch with people who actually work there, and they can suggest projects for you. And like Professor Clark said, you might not have all the time to go in depth into the project, but you can start and then maybe continue at master's level and even PhD level, or somebody else can continue. So it's possible. Make sure you're actually solving a problem, not just doing a project that nobody cares about or nobody's going to read about anyway. So yeah. So we're almost rounding off. So there's another question. Let me see. So someone is asking if he or she has an MSc in radiation biophysics and wants to know if you can work as a medical physicist and do a PhD. So the answer is yes, if you can get some clinical training, because it's kind of depends on anyway on the course content. I don't know where you studied your biophysics, but ideally you would need to get clinical training before practicing as a full staff. And yes, you can do your PhD in medical physics. Yes, you can do your PhD. Someone is also asking if first degree in physics also covers for physics electronics. I don't know what that means, but if you're asking if a degree in physics is the same with a degree in physics electronics, yes, I actually have my physics degree is with electronics. So, and I think it's you're actually better. I'm not trying to be biased anyway.
Very, very useful, I should think. Yes.
Exactly. Yes. So I can do some things engineers can do, at least to an extent. So it's a very good degree. Yes.
Yeah.
So what else?
We have a nice physics one there. If I've got time to answer that
one.
Okay.
Which one? Okay. Okay.
Radiotherapy treatment planning, MRI and CT. This is a very interesting one because traditionally you always use CT for radiotherapy planning. And one of the well, one of the originally the reason for this was that you got a very good picture that told you where the tumor was. But the other interesting thing is that if you do a CT scan, you actually pick up for each pixel in the image, you pick up something called a Hounsfield number, which gives you the attenuation of the X-ray in that particular pixel, and you pick that up for every pixel in the image. Now, from that, it's not totally straightforward, but from that you can work out how much the higher energy X-rays used for radiotherapy are going to be absorbed, and therefore you can do your treatment planning. So the very important thing about using CT for treatment planning is that it gives you this stopping power of the tissue. If you go to MRI, you don't actually get this information, because the MRI is using a completely different parameter to actually give you the image. It's using these relaxation times to give you the image. So you can't, from that, actually get the value. Now, what is happening now, and this is what's been going on over the past few years, we've moved from doing a CT and then putting the patient on the radiotherapy machine and doing the radiotherapy and using tattoos on the body to line them up correctly and that sort of thing. We now have something called cone beam CT, where you have a different system which actually images the patient while the radiation treatment is going on, or while they're on the couch. Now, then people move on and say, well, hang on, MRI gives us much better soft tissue images. We can find the tumor better. And so now what is being developed, and this is very much at the forefront of research, is MRI combined with radiotherapy. So you've got an MRI machine and a radiotherapy machine. Now, just stop and think about the physics going on there. In MRI, you've got a very intense field. You've got radio frequency fields. In radiotherapy, you've got an electron beam. What happens to an electron beam if you've got a large magnetic field? There's all sorts of wonderful complications there as to how you separate the radiotherapy and the MRI. Do them at the same time, and that allows you to actually change your radiotherapy beam depending on how the patient's tumor looks today. Because if you're having radiotherapy, external beam, you'll be having radiotherapy treatment every day for several weeks. And it may well be that the tumor changes size during that time, it shrinks. So if you have MRI combined with radiotherapy, it has fantastic advantages. But technologically, it's extremely difficult to do that. But it is being done by at least a couple of companies. Terrific work to do there in developing that. I'm sure Dan would come in on that one too, because he may have come across MRI and radiotherapy being done together.
I have, but I wouldn't want to say too much, because that does show my limit of physics. Because although I have a physics degree and I've worked in a physics department most of my career, I don't come close to having the right understanding for these clever MRI boys and girls. At some point during this next few days, I think you're getting a couple of specific lectures on MRI and imaging, and I will, if I can, I'm going to tune into those, because I think I can learn a lot from those people. So I won't say any more, Liz, but thank you for suggesting that.
Thank you so much. I'm afraid we have to stop now. We are supposed to close at 11 sharp. But if I can see there are more questions, please send your questions to the email address and we'll forward them to Dr. Parvin and Professor Clark, and we'll sure get back to you. Please, we need to stop now and do other things. There are lots of students here and I'm working. I need to go back to work. But well, thank you so much for the lectures. There have been very positive comments in the chat that your lectures are very insightful. And this is just like general overview. During the week, we're going to go in depth into this concept you have discussed today.
Yeah.
So tomorrow, we have a very exciting lineup of talks tomorrow, and we start at 9 a.m. So I want to encourage everyone to tune in tomorrow, same time, same station, same team, 9 a.m. And like I said, we'll answer your questions through the emails and we'll get back to you. Thank you so much, Dr. Parvin. Thank you so much, Professor Clark.
Sorry, can we get the soft copy?
Can we get the soft copy of the paper presented?
Hi, you put your questions in the chat, please. You can't just interrupt like that. Yes,
okay.
You already mentioned that the videos will be uploaded on YouTube, and we'll send the link to everyone. And the PDF, the presentations will also be sent to us. So please don't worry about that. We'll send everything to everyone who registered for the program. Thank you so much. It was great having every one of us here today. So
it's been fun.
Thank you very much.
Thank you, Professor Clark. Thank you, Dr. Parvin. Thank you, everyone. So tomorrow we'll continue at 9 a.m. Please download the full program on the website. We'll put in the link now in the chat. The NAMP website. You can download the full program of the. And please follow us on Twitter, Instagram. Tag us. Share your experiences about the Harmattan School. Tag everyone taggable. Tag the Medical Physics Harmattan School. Tag IPEM. Tag the Nigerian Association of Medical Physics. Yes. Thank you so much. Thank you so much. Thank you, Dr. Parvin. See you after the program. Professor Clark, thank you so much. Thank you, everyone. Bye-bye. See you tomorrow at 9 a.m. 9 a.m. tomorrow. Thank you.